Hello, everyone watching on YouTube. You are here with Eric Glazer and our esteemed group of panelists for Bright Spots in Healthcare's next episode. We are about to start in front of our live Zoom audience. Hello, everyone watching on YouTube. You are here with Eric Glazer and that's why I started early. There was a splash screen that allowed me to force me to keep the volume on. All right, here we go, folks. Let's have some fun today. Greetings, everyone, and welcome. This is Eric Glazer, and you have logged on to Bright Spots in Healthcare, produced by Shared Purpose Connect. Each episode we bring you here today, we focus on identifying not only important issues in healthcare, but we want to unearth for you bright spots, success stories that you, the listener, could determine if they can be applied at your organization, whether that be a health plan, a health hospital system or provider organization, or some other health technology or service organization across our country. We believe that this strategy of identifying bright spots and cloning them is the most effective way of improving healthcare in our lifetime. Our topic today is SDOH and diversity, equity, and inclusion. Know your hidden veteran population. And we have a perfect roundtable of experts to share with you insights and bright spots. I'm going to introduce them in a moment. We have a Q&A module. We have a packed agenda, but I'm going to do the best I can to integrate your questions in today's conversation. I know some of you submitted some upon registration. We have those carefully integrated already, but if you have some questions as they pop up during the discussion, click on the Q&A module, and Sherry Keels, our producer, and I will be reviewing those and making sure that we could incorporate them as best as we can. Additionally, we will be sending you in about 45 minutes yet another email asking for your feedback about today's episode. We ask you the favor of just taking 2 minutes, it's all it takes, to click on a few buttons and provide us some direction, not only in how we did today, but also on how we can improve our programming moving into the future. All right. Our esteemed panel. First, representing the payer perspective, we have Kacey Serrano. She is the Director for Medicare Stars and Risk Adjustment at Arkansas Blue Cross Blue Shield. Prior to joining Arkansas Blue Cross Blue Shield, Kacey has worked for a number of large national plans in Medicare Advantage, Stars, and risk market strategy, also in provider engagement and implementation of value-based arrangements. She has not one, but 2 Bachelor's of Arts degrees in biology and psychology and an MPH from the University of Arkansas. Go Razorbacks. Representing the provider view, we have none other than Secretary David Shulkin. Secretary Shulkin is a thought leader on veterans health and patient-centered care. He was appointed by President Donald Trump as the 9th U.S. Secretary of Veterans Affairs and served in that role from February 2017 until March 2018. He also served as the Undersecretary of Veteran Affairs for Health under President Barack Obama. And before his time in government, Dr. Shulkin had a long career of healthcare leadership and management, including at the University of Pennsylvania Health System, now Penn Medicine, as well as Temple University Hospital, Beth Israel Medical Center, and the Morristown Medical Center. Dr. Shulkin is a board-certified internist, and he received his medical degree from the Medical College of Pennsylvania, his internship at Yale University School of Medicine, and a residency and fellowship in general medicine at the University of Pittsburgh Presbyterian Medical Center. And last, and certainly not least, is Sean Libby. He is the president of BeneLynk. And prior to BeneLynk, Sean served as the president of Freedom Disability and Alpha Disability, one of the nation's largest Social Security, disability, and veterans advocacy companies. He is recognized by the Social Security Administration as a non-attorney representative and has personally represented a number of claimants in hearings for Social Security disability insurance and supplemental security income throughout the country. He is a graduate of Middlebury College and has a master's degree from a lesser-known institution called Yale University. He is also our first ever guest live on the show with COVID. So Sean, thank you for being here despite not feeling great. We appreciate you fighting through for us. He is also representing BeneLynk, who is the sponsor of today's Bright Spots in Healthcare podcast and webinar. BeneLynk is arguably the most innovative dual advocacy organization in the country. Their mission is to improve people's lives and positively impact social determinants of health barriers by granting their healthcare partners with the information they need while providing healthcare consumers with the advocacy they deserve. And I will give you a few more details on them later on the show, but if you want to check them out right now, you can go to their website, which is BeneLynk.com. I will spell that for you, BeneLynk.com. All right, let's get started here. I want to set the stage. Enough of me talking. Let's get all of our experts involved here. What I'd like to do is level set and talk about who are the players that support veterans healthcare in this country, and then talk about how does the VA support veterans. And so to do that, we're going to bring in Sean Libby and Secretary Shulkin. I'm going to start with you, Sean. Can you just lay out the players that support veterans healthcare in the country?
Sure, absolutely. Thanks very much, Eric. Thanks for having me. Thanks to my co-panelists. It's really an honor to be co-presenting with you. And thanks everybody for putting up with this voice. As Eric mentioned, I am on the tail end of getting over COVID and apologize for the raspiness. But yeah, so veterans obviously receive healthcare in all sorts of through all sorts of mechanisms throughout the country. They're in every aspect of our lives. But in particular, the mechanism to provide healthcare to veterans is the VA. And that's provided at low or reduced cost, zero or reduced cost, 1,200 facilities throughout the country to veterans. That VA is distinct from TRICARE. TRICARE is the mechanism that provides care to active duty military and their spouses and military retired who've been in for 20 years or more. So sometimes there's some confusion between the VA and TRICARE. VA is the wider system, 1,200 plus facilities throughout the country, providing care to veterans. And because of the demographics of veterans, a lot of them are older, a lot of them are seniors. There are a lot of veterans who receive care concurrently through the Department of Veterans Affairs and at the same time through Medicare or Medicare Advantage. That, of course, brings us to our topic today.
Great, thank you. And Secretary Shulkin, how does the VA support veterans and how do they coordinate with Medicare?
Well, the Department of Veteran Affairs' sole mission is to support those who have served the country. And as a cabinet level agency, it is the second largest department in the government of Veteran Affairs. There are 430,000 employees, a budget of close to $240 billion a year, which is only second to the Department of Defense. And there are facilities all across the country, in fact, even outside the country, to make sure that it can provide the types of services that veterans need. There is healthcare, of course, but there's also disability payments. And then there is the National Cemetery Administration, so that somebody who has served the country can feel confident that they're going to be seen and cared for all the way through being laid to rest with the respect that they deserve from their nation. In terms of Medicare, Medicare, of course, is another program that was implemented by Congress in 1965. The VA goes back well before the Civil War, but Medicare is for patients that are older or disabled. And there is actually no coordination between those programs. In fact, it's one of the things as secretary that I sought to do. It's called Medicare subvention. I wanted there to be an integration of the VA and the Medicare program benefit, because I think for a number of reasons, that would be better for the country, that would be better for veterans. But the big problem is that Medicare, the hospital trust fund, Medicare Part A, is going to soon be insolvent, which means it's going to run out of money in 2024. So anything that you do to touch that program, like integrating it with the VA, could actually shorten that period of time, which of course is politically a big problem, so that we've not been able to rationalize these systems, but it needs to be done.
So I'm gonna move over now to the health plan perspective, and why are some of the biggest health plans, and Kacey, I'm going to bring you in here. Why are they building specific programs for veterans? Like, I know there's probably some altruistic, clinical, and ethical reasons, but there's also probably some business reasons. And then Secretary Shulkin, I'll bring you back in if you want to comment on or expand upon anything that Kacey talks about from a Blues perspective. Go ahead, Kacey.
Yes, so within our veteran population, so I cover Medicare Advantage specifically. So we have a significant number of veterans enrolled in Medicare Advantage plans across the country. And within the state of Arkansas, we have 2 large military bases. There's a large veteran population even within our MA population. And one of the things that we're seeing is that our veteran population is a very unique subset of Medicare Advantage in general. They have a unique set of medical complexity. Outside of our typical Medicare Advantage patient that's dealing with chronic conditions, typically polypharmacy or a bunch of medications that they're having to keep up with, the typical social determinants of living in a more rural area or living in the South, or certain cultural differences and things like that of depending on where you live, those types of things. Our veteran population also has different components based on the service that they had, their experiences, the medical complexities that have arisen from their service. And so, you have the typical component of a Medicare Advantage member that as they age, their medications and their just medical situation in general is more complex. When you add in the veteran component, you're taking into account the different the increased rates of chronic conditions, the increased rates of things like PTSD or TBI. And so you have these, the increased clinical components. So we have to bring in additional benefits. But what this does in identifying our veteran population and building programs around it is it allows us to add benefits specifically catered toward the social determinants that we tend to see within the Medicare population, but specifically our Medicare Advantage veteran population. They have different needs. They have different things within social determinants or within medical complexity and complications. Also things like pharmacy, polypharmacy. They might get some of their medications at the VA and some from their local pharmacy. That's something that we can't address if we don't know about it. And so a lot of times on the front end, we're trying to just identify our veteran population. Once we can identify it, we can analyze the differences in our veterans versus our traditional MA patients, and we can compare those differences and build out benefits and programs specific to the barriers that are prevalent within our VA population. And that's something that we've done is really start to try to identify and analyze. And then from there, how can we cater our benefits, our supplemental benefits, our outreach programs to address the social determinants that are much, much more prevalent within our VA population.
Could you provide a quick example of, let's say, a simple program you have in place there that sort of creates a little bit of I don't want to say cures loneliness or anything or any key complexity that a veteran may have, but something that you're doing that maybe is reducing the negative impact of a social determinant in the veteran population?
Sure. So 2 of the big things that we see, loneliness is prevalent within our entire MA population. It's one of the biggest social determinants of health that we see throughout health risk assessments, conversations with members. It continuously shows up as the #1 social determinant in terms of prevalence. COVID and the pandemic made that exponentially worse. And so Arkansas Blue Cross specifically, we have welcome centers all throughout the state that members can go in and get things like assistance with benefits. We host member health fairs. And one of the things that we really started doing, especially in towns where we have a large veteran population, we have started doing social events. So things that get members out, and they might not have friends in their area, or they might not get exposure to other, seniors within the area, other veterans within the area outside of just their medical appointments. And so bringing in to do things like bingo, do things in some cases like knitting or, bunko or, different social things that we can do to just get members all in the same place, getting them socialized with each other. We've done walking groups and walking clubs, around some of the lakes in Northwest Arkansas. And we've really had some good participation in that it's an excuse for them to get out of their house and talk with people that they normally wouldn't have been exposed to. The other component we see specifically in a very rural state like Arkansas is food deserts, access to healthy food and not just fast food. The local McDonald's is the easiest thing to get food, but doing things like building in food benefits into our rewards, offering gift cards to grocery stores for getting some of those health screenings completed. We did a really unique thing this year in partnering with a vendor where if they complete a health risk assessment, which allows us to capture a significant amount of data on social determinants, we mail them a box of fresh fruits and vegetables instead of doing a $15 gift card. And we have gotten great feedback on that, and that members love it. And so being able to address some of those social determinants in very specific ways has really benefited our population.
Great. You might have just cost me McDonald's as a sponsor. No, that's okay.
Sorry.
That's it. Secretary Shulkin, I know I'm sort of putting you on the spot, but do you have anything to add there regarding health plans, building specific programs for veterans?
Yeah, I do. First of all, I really want to compliment Kacey. I think that she has both a really good understanding of the veteran population, of their specific needs, and has designed and tailored a number of interventions that are really effective. Now, having said that, this is where I'm going to get controversial. And it is not intended to criticize Kacey or Blue Cross Blue Shield of Arkansas, but I want to talk about this from a national health policy perspective. 22% of all Americans enrolled in Medicare Advantage plans are veterans. So there is a high disproportionate percent of veterans in these Medicare Advantage plans. And some of that may be the reasons Kacey talked about, because they require additional services. But what happens in Medicare and Medicare Advantage, like your prior question to me indicated, Eric, is that when one of those patients get care at the VA is not able to bill Medicare or the MA plan. And so therefore, if you think about these 22% of their enrollees, if they get care in the VA, let's say a heart surgery, the MA plan is paid the premium for that patient, but bears no cost. That's all borne by the VA. So this is really, from a national taxpayer perspective, something that I believe needs to be corrected. But as I said before, there are reasons why people don't want to touch the Medicare system at this point. So I don't believe it's on anybody's agenda. But you do have to understand that these plans, I believe, do better financially taking care of veterans.
That makes sense. And there seems to be a disconnect there. I have a follow-up for you. It's not exactly a follow-up, but I think it's sort of in line with the theme here, Secretary Shulkin. It comes from an audience member who just submitted the question. Would you consider including Medicare Advantage plans reimbursement models when evaluating the cost reimbursement models of critical access hospitals? Currently, only straight Medicare is allowed in the cost reporting model, and critical access hospitals are struggling to stay open. We have a large veteran population and would like to remain viable for many years to come. Could you comment and react to that?
Well, I think that that's a very good example of the opposite of what I was saying. Was that the health plans like Blue Cross Blue Shield of Arkansas, and again, not to pick on them, who are delivering care in these rural areas, are not getting the appropriate severity adjustments for caring for veterans in these very tough to care communities who are using critical access hospitals. And so therefore, that may be a financial disincentive to them, which is the opposite of what I was saying about veterans in their program that may be using VA facilities. That's a financial benefit to them. So I think that what we're seeing is the Medicare Advantage programs, which are really well intended. And by the way, Kacey did a great job of describing how these programs allow a health plan to offer additional benefits like loneliness and food. So that's a good part. But the reimbursement system has not really caught up in being able to accurately parallel the environment in which the patient, in this case, the veteran's getting care as a member of their plan.
I'm going to shift to now how we reach veterans and how do we initially identify them, that 22% that Secretary Shulkin just pointed out. Sean, I'm going to bring you in. Like, how are you see a lot of health plans, you work with a lot of health plans. How are you and how are they identifying veteran members?
Yeah. For us, it really is still very much a human-to-human engagement question. It's a challenge to open up conversations with members who we believe could be veterans and ask them the question. I'm often asked, sort of, is there a technology solution? Is there some master database we could hit? And the short answer is not really, no. And Secretary Shulkin did some wonderful things in his time there in trying to push the VA in that direction. And I really appreciate the work that he did. But generally speaking, in order to identify who's a veteran and who uses the VA, the best and most accurate way to do it is to identify a member that you suspect might be a veteran. We do that on our end using some algorithms, predictive factors, everything from demography to big marketing big data, and identify suspected veterans. And then we do outreach to ask them, are you a veteran? Have you used the VA? And we do that outreach with staff that's primarily either veterans themselves or military spouses, because it's all about sort of building that human-to-human engagement, right? So we want to be able to reach out to the people, say, hey, are you a veteran? Do you use the VA? We recognize that that's trying to open up a conversation. There's an element of trust there. We found that the best way to do that is to have veterans calling veterans, or in some cases, even better, to have military spouses calling veterans to ask about their experiences.
Let's talk about challenges engaging them, Sean. And I know Kacey had listed a few as a preamble to her initial answer on the question, but I want to bring in and get you and Secretary Shulkin's perspective too. So all of you go first, Sean. What are some of the unique challenges in engaging these veterans? And then I'll pass it on to Secretary Shulkin.
Yeah, I think that the number one thing is just to recognize, in particular, if you're talking about identifying VA utilization, that despite, again, the great efforts that have been made at the VA, a lot of them spearheaded by Secretary Shulkin, there still remains a local system. And the conversion, for instance, over to the Cerner system, electronic health record system that they're still working on, is still very much a work in progress. So in order to identify veterans and VA utilization, we still treat it very much as a local initiative. So we want to ask the vet, we want to do that human-to-human outreach, say, are you a veteran? Do you use the VA? And then understand specifically what VA facilities, including what are called CBOC, community-based outpatient clinics, you might use, so that we really understand at a granular level where that member is receiving care through the VA. It's in theory a federal system, but in practice it functions very, very locally. So what we found is that the key to that, the challenge that you have to overcome, is to really engage the specific member and understand specifically how it is that they are using the VA.
Secretary Shulkin, what are, from your perspective, unique challenges in engaging veterans?
Well, first of all, I think you have to remember that there is no general description of
we lost you there, Secretary Shulkin. Could you go?
I'm sorry.
Let's start it off again. There's no general. Just
yeah. I hope you can hear me better. I just want to reinforce that there is no general characterization of the veteran community. There are veterans who are 20 years old and veterans who are 100 years old. And there are veterans who come from both every racial and cultural group in the United States, as well as females and males. And so therefore, we have to design our engagement strategies depending upon where the veteran is and not necessarily where we want them to be. But I think that Sean did a great job of identifying three key factors in engagement. The first was that you really do need to identify the issue of trust. And when I first got to the VA, there was a broken trust with our veterans, and it was very hard to engage them if they didn't trust you. So we had to rebuild that trust to open up that communication. The second that Sean mentioned was peer support. And I think he's exactly right. In fact, it's what I call the superpower of the VA, that VA can utilize the power of peers and family members of veterans to engage them. And then third, I think Sean also got this correctly. You have to look at everything in the context of the local community. And it can't just be the VA reaching out to the veteran community. It needs to be done in coordination with the community, whether that's veteran service organizations, not-for-profit groups, state and local governments, churches, synagogues, mosques. This is really an integrated effort to reach the veteran community.
Great. And to the audience, a couple things, PSAs. One, keep the questions coming. I will start. I'm trying to get through them, as you could probably tell. Just make sure you use the Q&A module. I can't follow chat as easily. So if you ask a question via chat, copy it, throw it in the Q&A module. Much better chance I'm able to ask it that way. Also, as you probably could tell, Secretary Shulkin's in transit right now. He's gone above and beyond and trying to participate today. So every so often, if we're having some transmission problems, we may swing back off that question and back to him when we get to better connection. All right, Secretary Shulkin, if you could hear me, I know the answer to this, but I want to make sure you're clarifying for one of our audience members. You already mentioned this, but does the VA get paid for Medicare for services in the VA, inpatient or outpatient?
No, it does not.
Okay. Thank you for that. All right. We are going to now, let's get into the impact of just really understanding veterans and collecting data on them and the documentation process and the value that all of your businesses could derive from really better understanding your population, especially the veteran population. Before we do that, I just want to provide another quick shout out to our friends at BeneLynk. Without them and without companies like them, we cannot do this show. And I wanted to give you some more detail around them and why we handpicked them for topics like this. Because even though, yes, they are funding the show, we have the luxury of Bright Spots in Healthcare and handpicking organizations that provide deep subject matter expertise on the topics that we know are important to all of you. BeneLynk is a national provider of social determinants of health solutions for Medicare Advantage and managed Medicaid health plans. They serve plans and their members by creating a human-to-human connection and then providing the assistance a member needs to get the benefits they deserve. You heard that from Sean just earlier. And they also use technology, innovative technology, that enables their team to have a dynamic conversation that flows organically to meet the social determinants of health challenges that that individual on the other side of the phone is facing, and be able to build strong human connections with that individual. And this is carefully planned, and that combination of human touch along with technology generates exceptional results. And I get the privilege of talking to a lot of companies in this space, and I truly believe that BeneLynk is changing the way the healthcare industry communicates and builds relationships with consumers, especially veterans with complex healthcare conditions, and believe they are a true bright spot in healthcare. So I encourage you to connect with them. They are great resources, even if you're not going to hire them. And at the end of the show, and actually 45 minutes past the hour, there'll be an email with the survey. You could request an introduction to them. I will not just hand your name over to them. I will email you and someone at BeneLynk, probably Sean or someone on his team, and introduce you to them so you could pick their brain. And incidentally, speaking about picking their brain, as a preparation for this session, I was able to read this great white paper called Veteran Status, an Under-Recognized Social Determinant of Health and Medicare Advantage. It's written very clearly, almost like USA Today quality writing, and I say that as a compliment. If you guys want a copy of that PDF, so you don't need to find it online or register for anything, I'm happy to send it to you. I'll have Sherry Keels, our producer, put up a poll. Anyone that wants the PDF, I'll email it to you after the show. All right, let's bring back Kacey Serrano. Kacey, what is the impact at Arkansas Blue Cross Blue Shield? What's the impact and the value of a strong documentation process? And how have you been able to derive value as a business from getting better at that?
So I think the first component is the identification. And I know you just talked to Sean and Secretary Shulkin about that. For an MA plan, we have a kind of a multi-pronged approach in terms of identification. So we utilize BeneLynk for several of those services, including help with identification, help with record retrievals with VA, data collection, social determinants, predictions, things like that. We also have within MA in general, a pretty active sales process during AEP. A lot of you guys are familiar with that. It's part of our question and answer during the sales process. So we have a lot of different ways to touch members even once they're enrolled also. So within our quality programs for Medicare Advantage, we have pharmacy outreach, we have quality outreach, we have case management, social work, a lot of different components that might touch members throughout a various point in the year. It's part of our conversation with them because every single component or every single one of those components might be handled differently if the member was a veteran. For example, pharmacy, and if they're late to refill their medication, it could be because they found out it was cheaper to fill at the VA. And so they're now filling at the VA and we don't have that information. And so we might cater our conversations differently once we identify that they are a veteran. So, through sales, through internal touches, we also include it in our health risk assessment because, like I said, that allows us to cater the conversations because they do have a unique subset of healthcare needs. And then from there, what we really do is try to cater our conversations, cater our healthcare services to our veteran population. So for example, we have a social worker within MA that might be able to cater specific conversations and ask specific questions related to their veteran experience, especially because we know of those increased rates of mental health conditions or, exposure to hazardous material type things, different aspects that might have been impacted by their veteran status and have them be at an increased risk for certain conditions. It allows us to address those. I know earlier we were talking about revenue and things like that. Yes, we do get data and we submit that to CMS to drive revenue for us. Medicare Advantage plans get paid based on how sick our members are because they use that data. They use that Medicare data to predict how sick our members are, which should in turn allow us to pay for those members is basically a general explanation of how Medicare Advantage works in terms of revenue. But one of the things those dollars do is also allow us to build programs around benefits. So increased hearing benefits and vision loss, which are also more prevalent within our veteran population. Case management services specific to veteran service and being able to cater questions and do research based on our veteran population and how their diabetes should be managed based on the other social factors we talked about versus just a standard Medicare Advantage member and trying to manage their diabetes. So there's a lot of different components that we utilize the revenue. We might not be, paying for the heart surgery like they mentioned, like Secretary Shulkin mentioned at the VA, but we are using it to build out supplemental services to better handle overall wellness and overall healthcare for our members, and not just specific services and procedures that they're getting at the VA. And so really trying to get accurate information, accurate data. We use that kind of a multi-pronged approach, everything from utilizing sales, utilizing BeneLynk, utilizing internal conversations and member touch points. But how do we impact the overall well-being of not only our Medicare Advantage population, but how can we better impact the overall well-being of our VA population? And that's what we've slowly been trying to solve for by looking at things like case management, social work, pharmacy, chronic case management, things like that, all the different ways that we touch members on a daily basis for our Medicare Advantage plans.
Great. I want to keep you on the spot here, and then I'm going to take some questions from the audience. I'm going to bring Sean and Secretary Shulkin in. What role does, actually, I may even bring Secretary Shulkin into this question too, but Kacey, I'm going to have you go first. What role does SDOH play in risk adjustment, payment, and patient outcomes measures?
Oh, that's a loaded question. So as of right now, social determinants are not tied to revenue. We can capture social determinants all day long, and they are not technically tied to revenue, financials, things like that. However, in the space of taking care of our members, in the space of overall medicine and the cost of medicine, it has an enormous impact. It's something as simple as the example I mentioned earlier, where if fast food is your only option versus a healthier option with getting fresh fruits and vegetables from a local grocery store, if your local grocery store is 40 miles away, then you might be eating fast food for every meal. That is definitely going to contribute to a higher rate of things like high cholesterol, hypertension, diabetes, chronic conditions. And not only does that impact their overall well-being, but that impacts their cost of care. Those members are going to be exponentially more expensive to treat, whether they're a veteran member or whether they're a standard VA or a standard Medicare Advantage member. So that is going to cost money to the VA system. That's going to cost money to any health plan that takes care of those members. And so things like food deserts and food insecurity is very important. On the opposite side of that, you have malnutrition. If they're not getting the nutrients that they need, additional dental work, additional mental health work, all of those additional things greatly impact the cost of care. You also look at things like health literacy as a social determinant. If they don't understand how to take their medications, that could have significant impacts on cost of care because they could be rehospitalized because they're not taking their COPD, their nebulizers or their CHF medications, things like that. So, the social determinants aspect really does impact the cost of care. We're seeing governing bodies and organizations like CMS, NCQA, PQA, and others really starting to recognize the impact of social determinants because it's becoming a real big buzzword in terms of data analytics within healthcare right now. And so we're looking at ways to track it. We're looking at ways to capture that data. They actually introduced ICD-10 codes for social determinants. So we are starting to educate providers on capturing that information because we as a health plan can offer services for transportation issues, food insecurity, a lot of different aspects of social determinants. So if we have the data, we can assist the members, but we can't do anything until we identify them. And so we're really seeing that trend shift as CMS and all of the other organizations come out and really start talking about social determinants. I think we're going to see a pretty significant shift in actually taking it into account of the impact of cost of care in the future, the immediate future.
Secretary Shulkin, do you have anything to add or a different perspective on what role SDOH plays in risk adjustment, payment, and patient outcomes measures for veterans?
Well, once again, I think Kacey's done a really excellent job of describing the current situation and the reason why social determinants are important. In the VA system, it does not work that way. Social determinants have always been part of what the VA system does, and this is not something new. The VA has a system of documentation that actually focuses on something completely different, and that's whether the veteran is being treated or cared for because of a service-connected issue. Is it something that happened because of their time while they were in the military? And your benefit levels can vary depending upon whether something is considered service connected or not. And so that's really a very different way of looking at things than the way that Kacey is describing it in the private sector. But I think for those patients and those veterans that have the greatest needs, whether they're being met in the VA or out in the private sector with Blue Cross Blue Shield of Arkansas, addressing the social determinants, like Kacey said, is exactly the right thing.
I'm going to, if you could hang on, I have another question for you, Secretary Shulkin, from the audience. And by the way, and I know it's going to sound like I'm just saying this to all of you listening, and especially those of you attending live here by Zoom. These are some of the best audience questions I've ever seen. So, and I'm not just saying that if you're a regular on the show, I usually don't go out of my way to say that, but you could just be moderating this without me here. So Secretary Shulkin, some would argue we are over medicalizing social problems. How do you counter that argument?
Over medicalizing social problems. Well, look, I think that these are artificial distinctions and silos between a person's health and well-being, what we categorize as in the medical system, and what we categorize in the social systems, whether it's family units or social services. So I think what you're beginning to see finally is a recognition that there needs to be much more of fluidity between these various systems. And so I'll give you the example that I spend a lot of time dealing with, which is veteran homelessness. Today, we have 45,000 veterans who are homeless in this country. It's a shocking number. But one could say, look, homelessness is largely a healthcare issue. That if you look at the reason why many veterans are homeless, it's because they have behavioral healthcare issues, or they have the inability to work because they're disabled from a medical issue. So you could approach it that way. But what we know is if you take a city like Washington, D.C., the average cost to the District of Columbia of a homeless person is $400,000 a year, because these people are constantly rotating in and out of emergency rooms. They use emergency medical services from the city, and they use a lot of police activity as well. And so therefore, using money that is on one part of the budget, maybe in the fire department or the police department, to help support a medical component for a homeless person just makes a lot of sense. But there is no easy mechanism to do that or to provide housing necessarily. So that's where the Department of Veteran Affairs does step in, and it works with the Department of Housing or Urban Development, issuing vouchers for housing. It works with social agencies, it works with medical organizations, but it shows the need to think about these various agencies more along a continuum rather than as individual siloed organizations.
I'm going to take one more question from the audience before we get back onto our script. While I do that, I'm going to bring in you, Sean, to start, but I think all three of you could address this question potentially from your own perspective. Before we start, before we go there, just want to let everyone know when we're thinking about our programming, and again, in about 4 minutes, you'll get an email from me asking for feedback on our programming and what we could do for you to better serve your needs and make this hour an hour well spent for you. We try to string together topics that we know are relevant to your business. And so next week, next Thursday, 12 o'clock, whenever we do our live recordings, we're going to talk about how conquering loneliness is a key to your Medicare and Medicaid businesses. And this is being sponsored by Pix Health. And so that show will include Santine, Molina, and others. It won't be veteran specific, but of course it'll be covering topics that are related to both your entire Medicare and Medicaid business, as well as your veteran population. So if you'd like to attend that one and you want to go through the registration process again, which isn't that cumbersome by now, Sherry will put up a poll. If you click yes, we'll register for you for next week's live episode at 12 o'clock on Thursday on loneliness. Okay, I'm going to start with you, Sean. I'm not sure you could tackle this. I'll then quickly go to Kacey and then over to Secretary Shulkin if everyone wants a comment. How can MA plans access their members' VA records to identify rising risks and quality of care gaps when members rely on the VA for their PCP relationship, and the plan might not see the member until they hit the ER?
Right. I could have written that question because that's basically really at the core of what we do, right? And this is really about meeting the VA system where it is currently, as opposed to where maybe we wish it was. So what we've done at BeneLynk is we built a system where we kind of, first of all, engage the veteran, talk to the veteran about the care they're receiving, understand specifically what VA facilities they use, and then we gather the individual veteran's authorization to get documentation of their care. We do that on a VA form called 10-5345. The member tells us specifically what VA facilities they use, and they specifically say, I want you to share this information with my Medicare Advantage plan so we can bridge this gap between these two organizations. We then use that authorization to go to the VA facilities. And again, now we're looking to be a good stakeholder, good partner with the VA, understand the local VA. How do they want to receive requests? How can we work best with them? We give them that request, we retrieve the records, and then we share them with the Medicare Advantage plan. So really it's about building this whole ecosystem where everyone understands we want to make sure there's two silos of care. Nobody wants the siloed care. So we really want to break it down. So we start with the conversation with the veteran. Where are you receiving care? Do you want to share that information with your Medicare Advantage plan? Bring that to the VA, gather the documentation of that care, bring it over to the Medicare Advantage plan. And that way the MA plan can really fully understand and be the medical home for that veteran to understand all the care that their member is receiving.
Nice. Kacey, do you have anything to add or different perspective?
So just to add to that, we utilize BeneLynk for this service to be able to retrieve medical information for our Medicare Advantage members. And we have seen a significant amount of data and information and just an overall picture for our Medicare Advantage members that are also veterans and utilizing VA services. And so it's been a really successful program for us. There's a lot of data that we wouldn't have been able to capture otherwise. There's been everything from social determinants data to chronic condition data to information that we would, review pharmacy information, case management programs we can enroll them in. We offer things like diabetes management programs and diabetes cooking classes and things like that. We can share community resources. We wouldn't have known that that member was a diabetic, or we wouldn't have been able to identify that patient's medical history if it wasn't for being able to capture that information. And so I think being able to have insight into the services that they're receiving at the VA is also beneficial, because we have relationships with primary care practices throughout the state, and we can share that information as well. Their PCP that they are seeing outside of the VA might not even be aware that they got a colonoscopy last year and it was an abnormal result, or that their VA physician is also prescribing them, a statin medication or things like that. And so it's really valuable information, and we have found a lot of benefit from having it.
Secretary Shulkin, do you have anything else to add?
Yeah, I think both Sean and Kacey described a really important need. In order to provide good care, you need to have the data that's happening at various sites. The VA, of course, has tried to work on this issue, as far as I can tell, dating back to at least well before the turn of this century, quite unsuccessfully. The first thing that they did, though, was they implemented a program called the Blue Button. So every veteran has the right to be able to download their entire medical record history onto a disk and carry that to another provider. So theoretically that would work, but I'm sure Sean will tell you not many veterans know how to do that and probably don't do that on a regular basis. Secondly, the reason why I made the decision to move away from VA's beloved homegrown electronic health record called Vista to a commercial system, in this case Cerner, was to address this data interoperability issue that Kacey talked about, that's so challenging, and why Sean's company is so important. But ideally, sometime in the far future, with a 10-year implementation plan, there should be the ability to do data interoperability of data, so it just flows naturally. But until then, we're going to very much need the types of solutions they're talking about.
That's great. Incidentally, and probably going to embarrass you, Secretary Shulkin, but for those of you who are new to the show, Secretary Shulkin was on my show for a one-on-one about 6 months ago, give or take. If you go to Bright Spots in Healthcare and type in Shulkin or Secretary, you will find that interview. It was a great conversation. In preparation for that interview, I read Secretary Shulkin's book, It Shouldn't Be This Hard to Serve Your Country, and I highly recommend it. Really, if you're interested in veterans and veterans healthcare, I highly recommend you that book. I did it on Audible. It took me like 2 days to get through. It was that quick of a read or listen. So I'll post actually the Amazon link in this.
Thank you.
Sorry, Secretary Shulkin. It was just that good. I think people should know about it.
Okay.
All right, let's get back. Kind of still on time, barely. So, Kacey, as a result of all this work and collecting all this data, was there anything you were specifically surprised about?
I think it was the amount of information that we didn't have as an MA plan. Things like the social determinants results that we were seeing and that were documented, because a lot of times the comprehensive visits that they're done at the VA are not the same as what's being done in a standard PCP practice. They're asking specific questions catered to members that have served in the military. They're asking about specific experiences, a little bit different questions, a little more deep dives into mental health things around PTSD and things like that, which we typically don't get from a standard primary care physician's office. And so being able to really dive into that information and then also see the benefits of some of the supplemental benefits that we offer, and that maybe they were trying to get a certain kind of hearing aid from the VA, but something that the MA plan offered was a little bit better or a little bit easier for them to get, that they could get at no cost through us. And so it allowed us to help coordinate some care for some of our veteran population just through the data that we found within the documentation. And so the VA specific questionnaires and questions and clinical practices that they have are slightly different than what we see outside of the VA. And so just being able to compare that and then document the additional information the VA was able to capture was really valuable for us.
Sean, anything to add to that or talk? I know we covered it a little bit already, but the value that health plan derives from understanding all this, the care that the members are receiving at the VA, or just in general around social determinants?
Yeah, I mean, Kacey has obviously implemented a great program. They make what we really hope, right, is to make all the uses of the data. Right now, you understand this additional information about your member. So who can use this and how can you make a better healthcare experience for the member based on this new information, right? And that should inform everything from customer service to medical management, risk adjustment, quality, all throughout, right? So, Kacey's success there is obviously, kind of the model of what we hope everyone can achieve. In terms of one thing I would want to mention is the quality gaps, right? That there really is this opportunity to say there might be care that is being received there. What Kacey was just describing is the annual wellness exam, right? That veteran is going to be receiving at the VA. If because they're receiving that annual wellness exam at the VA, they are in turn not getting another physical out inside the Medicare Advantage network, then you're creating this situation where there's this disincentives, there's weird incentives, right? The Medicare Advantage plan needs to get these measurements done and that they can't get done because they're getting done at the VA. So it's a challenge, right? So that's when they are getting that care done at the VA, being able to get that information and document that quality is really, really important.
I'm going to continue on with some questions from the audience because they are so interesting. I guess I'm going to start with Secretary Shulkin on this one and talk about cultural diversity. And this attendee wants to know how are you? And I don't think she's necessarily addressing you specifically, but how are you as a panel addressing cultural diversity, engaging veterans in SDOH?
Well, I don't think that there's one answer to that, but I think it all starts with listening and understanding the people that you serve. And so as secretary, I would spend a great deal of time trying to understand what the needs and experiences of the veteran community are. And fortunately, the veteran community has many organized groups that can help do that. These veteran service organizations, of which I today sit on the board of several of them, are there in order to gather that feedback and to really provide a candid view of what the experience is like. We know for sure that while racial disparities still exist in the VA has probably done a better job than the private sector, and because they've been at it longer and the issues of racial disparities have been known in the military system and the VA system for a while. More recently, the VA has had to learn the hard way about gender disparities, and with the issue of military sexual trauma and the issue of women not being treated the way that they should, as respectfully and dignity that they deserve, we've had to build separate women's health services with separate entrances to VAs and separate staff. So the VA is still trying to get this right, but it is targeting resources and efforts and making it a priority to address both gender and racial disparities.
Kacey, I'm looking at the Q&A module. You seem to be winning most popular here. A lot of questions with your name on it. I'll ask you this one first. The information that you referenced from the VA about your veteran members, is this something that you requested from BeneLynk, or is this something that the Blue Cross Blue Shield Corporation wide effort that all of their MA plans do and get?
So as Blue Cross, we're an independent licensee of the Blue Cross Blue Shield Association. So there are probably other plans that work with BeneLynk. We chose to work with BeneLynk specifically just because of their reach within the VA and their reach within our veteran population. So we contracted directly with BeneLynk, and we provide as much member detail and information as we can. And then they also have their own internal algorithms and resources to help us identify veterans. So we have basically solely outsourced this to BeneLynk in terms of gathering data and predictive analytics around our veterans. And so I'm sure there are other Blues plans that he works with, but we work directly with BeneLynk for that as an MA plan.
Got it. And Sean, if BeneLynk shares that data with discrete data elements in a report, does BeneLynk share the data with discrete data elements in a reportable format or just medical records?
Yeah, that's a great question. So when we think about veteran status as an SDOH, the first thing that we report is, is somebody a veteran and do they use the VA? And we do that for everybody, whether or not they use the VA, and that's a discrete data element. However, once we're talking about the actual chart, we are not a coder, we're not a HEDIS abstractor. So our job is to to be an engagement arm, to reach out to those veterans, to get the records, and then to turn them over to our managed care clients. And then they do the coding, they do the abstraction. So we really don't do anything with the chart in between. We just verify that we've gotten all the information we need and then hand it over so that the plan can do the good work that they do.
Secretary Shulkin, here's a question that I think you're going to be best suited for. Let me see if I could get it. It's a long one. What would be a strategy to take better advantage of the veterans with military medical training to help support healthcare shortfalls? Case in point, the MMAC program in Virginia. 2014 AHA attempted to get the word out, but few hospitals understand these human resources are available in communities across the nation. Can you comment on that?
Well, I think what the person asking the question is very aware of is that one of the most significant issues facing the healthcare sector right now, whether you're in federal healthcare or private sector, is the workforce shortages. With 22% of all healthcare workers having retired or left the workforce in the past 2 years, there's not an easy answer to this. So I think that when you take a look at why we are seeing so many difficulties with hospitals, health systems getting staffed, you can point right back to these regulatory reasons. The insistence that every provider gets state licensure, be credentialed in individual plans, frankly, are protectionist systems that prevent Americans from getting good quality care. And frankly, it is the professional societies that are keeping these systems in a self-interest still alive. I think that when you look at the military system, which is what the questioner is asking about, somebody who comes out of the military with excellent training and could have direct applicability in the private sector is being challenged because their licensure, their certifications don't match exactly what the states are requiring. And so therefore hospitals can't hire them and let them practice in the setting that they're actually trained to do it. So it requires legislative efforts to overcome these barriers. And there's never been a time like now that we need to do that. So I think your listener, the one who's asking the question, is exactly right in that it's not really a question. I think they're making a statement that it's time to do this.
All right, we have 2 minutes left. I'm going to ask a question that all of you could comment on. I just try to be as concise as you can here. What is the greatest community attitude that impacts SDOH and the veteran community? In other words, is there any initial data about community attitudes towards veterans and their health? I'll start with you, Sean. I'll then go to Kacey, and we'll end with Secretary Shulkin.
I don't know if it's precisely answering the question, but I guess what it sparked in me is one thing my experience of veterans as a social determinant of health is just that veterans want to tell you they're veterans in most cases. It's an important part of their life story, and they really want to share it, right? So it's a social determinant of health that really informs how you can interact with them and who they are. And gathering that information and really engaging them is a really important way for anyone in the community, anyone who's looking to optimize the healthcare for this individual, understand that part of their life story. So I'm not sure it's exactly answering the question, but it did spark for me a little bit it's important to remember that this is a social determinant of health, yes, and it's also one that the veteran wants generally, I'm generalizing, the community to understand.
Kacey?
I think for me, it's just understanding that not all veterans have the same background, same personality, same healthcare struggles, same experiences. And so while this population of veterans might be struggling with homelessness, this population of veterans are thriving and they're doing well and their overall healthcare hasn't been impacted. And so it's important to remember as a plan or as a community member or really anybody that touches a veteran population is that you cannot generalize when it comes to veterans, but you can target approaches based on the prevalence that you see within that population. So take the big gorilla in the room first, whether it's, food insecurity, homelessness, whatever the data shares is the most obvious option or the most prevalent option, and start there, but understanding that that's not necessarily going to be the case for your entire population.
Secretary Shulkin.
Well, it's always dangerous to give me the last word, but I think Kacey has again done a nice job of saying that there is no generalization of who a veteran is. They all have different needs. We have 20 million American veterans. There are 5.5 million veterans that have caregivers in this country. Having and supporting our caregivers, like what's done at the Elizabeth Dole Foundation, is so important, because those people without them would have to be, in many cases, institutionalized or worse. But I think the important point here is that not all veterans need help. Many veterans are out there actively contributing, very, very productive. But those that do, it should not be as difficult as it is to get help. And I was down in Washington yesterday meeting with senators about the burn pit toxic exposures. When you've been injured serving your country, you shouldn't have to come back and have to fight the way these people do just for the care that they need. So I think we need to help them. And that's why, and I appreciate you mentioning my book. The title of my book is "It Shouldn't Be This Hard to Serve Your Country."
And that is a perfect bow on today. I want to thank everyone who's listening to the podcast or listening live today via Zoom. My team and I take the hour you spend with us each week very seriously and work very hard to make sure this is an hour well spent. So we thank you for taking the time. We produce this podcast for you. To our panel, I ask you to stick around for just a moment, but thank you so much for all the preparation, all the work you did today. And in preparation for that, really appreciate it from all three of you. I want to remind everyone, next week, 12 o'clock, we'll record live again. You could come. And this is your Bright Spots in Healthcare podcast. Take care, everyone.